All right, team, let's talk RadBio. Specifically, the absolute bedrock, the foundational principles and basic units of radiation protection.
Yeah.
If you're staring down your boards, navigating call, or just aiming to feel completely solid in clinic, this is, well, non-negotiable stuff.
Right.
We're not just reading definitions here. We're going to unpack the why behind these rules and numbers.
Exactly. Because understanding them is key to everything, really.
Yeah.
Shielding design, patient safety.
Even how you counsel someone about risk.
Precisely. Think of this as a concentrated tutorial session. We're going to build that essential framework for radiation protection.
Okay.
Covering the two main ways radiation interacts with tissue, the effects it causes, how we actually measure radiation, quantify.
And the ethical principles, too.
And the core ethical principles that guide us. It's fundamental knowledge, connects directly to things like cell sensitivity, organ tolerances we've maybe touched on before.
Okay, let's dive right in then. First big piece, recognizing the kind of damage radiation can do. We split these into two main buckets, right? Deterministic effects and stochastic effects.
Yeah.
Let's hit deterministic first.
Right, deterministic effects. Sometimes called tissue reactions.
Mm-hmm.
These are like predictable outcomes that only happen above a certain dose threshold.
A threshold.
And the severity. It's directly linked to the dose you get above that threshold. Below it, you just don't expect to see the effect.
So if you don't hit that critical dose level, nothing happens. But once you cross it, more dose means a worse reaction.
Exactly right. The mechanism underneath is usually widespread cell killing or severe functional impairment in a tissue. You basically lose enough crucial cells.
The tissue just can't do its job anymore.
Precisely. Organ function loss.
Give us some classic examples we might see or hear about.
Well, on the really high dose side, you have the acute radiation syndromes, hematopoietic, GI, CNS. More clinically, things like skin reactions, erythema, desquamation, necrosis. Those are definitely dose-dependent, have thresholds.
Okay.
Lens opacity, cataract formation, clear threshold there.
Yeah.
Sterility, radiation fibrosis, severe fetal abnormalities. These are all typically deterministic.
So the goal of radiation protection for these deterministic effects seems pretty straightforward then.
Yeah.
Just prevent them. Keep doses below those known thresholds.
That's exactly it. Identify the threshold for a specific tissue reaction. Make sure your dose stays under it.
Simple enough in principle.
There's an analogy that sometimes helps. Think of like damaging a complex machine, a car, maybe a few small scratches, minor dents, damage to just a few cells. The car still runs fine, right?
Sure.
The system can handle minor hits. But if you cause enough critical damage, puncture the radiator, crack the engine block, kill or really damage a ton of essential cells, the whole thing stops working.
System failure.
Right. There's a point. That threshold level of damage where it fails, that's deterministic.
Okay, that clicks. Makes sense for tissue failure. Now let's switch gears. The other side, stochastic effects.
Right.
These are the ones we often call probabilistic or chance events.
Correct. Stochastic effects are fundamentally different. For radiation protection, we make a conservative assumption.
Which is?
That there's no threshold dose. This is the basis of the linear no threshold model, the LNT model.
Yeah.
Any dose, doesn't matter how small, is assumed to carry some probability of causing a stochastic effect.
Okay, so unlike deterministic, you can't say below this dose, you're totally safe. But the risk still scales with dose, doesn't it?
Yes, exactly. The probability, the chance of the effect happening goes up with the dose. Higher dose, higher chance.
Then this is the key difference, right?
This is the crucial distinction, yeah. If the effect does happen, its severity is independent of the dose that kicked it off.
Meaning?
Meaning a radiation-induced cancer is just cancer. Its aggressiveness isn't tied to whether it came from a low dose or a higher dose. The dose only affected the likelihood you'd get it in the first place.
And the mechanism here isn't massive cell death like before. It's more like damage to just one cell or a few that then go wrong.
That's the current thinking, yeah.
Yeah.
It's thought to arise from damage mutations, chromosomal aberrations in maybe just one or a few cells that survive the radiation hit and then proliferate uncontrollably. It's that initial cellular event that leads to a probabilistic outcome for the whole organism.
And the main examples we worry about are cancer.
Cancer induction, carcinogenesis, and heritable genetic effects. Those are the two big ones for stochastic.
Okay, so since we assume no threshold, the goal for protection can't be prevention, because that means zero dose, which isn't realistic.
Right. It's not prevention. The goal is to limit the probability to a level we consider acceptable. It's about weighing the benefits of the radiation exposure against those potential risks.
It's probably worth mentioning, too, that if you got a really high dose, you'd likely run into severe deterministic effects long before any potential stochastic cancer showed up years down the line.
That's an important point for perspective, yeah. Especially when thinking about high-dose exposures.
Okay, let's try a quick practice scenario. Say you're talking to a patient about potential side effects from their radiation therapy. You explain the deterministic stochastic difference. Then you mention temporary hair loss in the treatment field.
Okay.
Based on what we just discussed, is that temporary hair loss mostly stochastic or deterministic? And why? And how does that compare to, say, the lifetime risk of a secondary cancer from the treatment?
Okay, good one. Let's break it down. Temporary hair loss. Does it happen with any tiny dose? No. Does it only kick in above a certain dose level? Yes. Does more dose cause more hair loss, maybe even make it permanent? Absolutely. So that pattern threshold, dose-dependent severity that screams deterministic effect, it's a tissue reaction in the hair follicles.
Right. Fits perfectly.
Now, contrast that with the secondary cancer risk. Is there some risk, theoretically, even with a very small dose? Yes, under the LNT model. Does getting cancer depend on hitting a threshold dose? No, it's probabilistic. If a radiation-induced cancer does develop, is it somehow worse because the initial dose was higher? No. The dose only influenced the chance it would happen.
Stochastic.
That's the hallmark of a stochastic effect. So temporary hair loss, deterministic, secondary cancer risk, stochastic. You really need to grasp that difference for patient counseling and, yeah, for board questions, too.
Great clinical tie-in. Okay, so we know what radiation does, but how do we actually measure it, quantify it? Let's transition to the basic quantities and units you absolutely have to know.
Right. You can't apply protection principles if you can't measure what you're dealing with. 3 fundamental quantities we need: radioactivity, exposure, and absorbed dose.
Let's start with radioactivity. What's that telling us?
Radioactivity measures the amount of radioactive material you have, specifically the rate it's decaying, undergoing nuclear transformations. It's about the source itself, not really the radiation field or the dose delivered.
And the old unit, the conventional one we still see around, especially in NUC-Med and brachytherapy.
And the Curie, symbol CI, defined as 3.7 times 10 to the power of 10 disintegrations per second. It's actually a huge unit, historically tied to 1 gram of radium.
But the modern unit, the SI unit, is the becquerel.
Yes, the becquerel, BQ. Much simpler. 1 becquerel is just 1 nuclear transformation or 1 disintegration per second. Per second.
And you absolutely, positively must know the conversion between Curie and becquerel for your exam.
Oh, yeah. This is a key one to lock down. 1 Curie CI equals 37 gigabecquerels GBQ.
37 gigabecquerels.
Which is the same as that 3.7 times 10 to the 10th becquerels BQ. Going the other way. 1 BQ is tiny. It's about 27 picocuries. But definitely memorize. 1 CI equals 7 GBQ.
Got it. Next quantity. Exposure. What's exposure measuring?
Exposure measures the ionization that X-rays or gamma rays produce in a specific mass of air. It basically quantifies how well the radiation field can ionize air molecules.
And the conventional unit is the Röntgen, or?
Correct. 1 Röntgen are defined by the charge produced per mass of air, 2.58 times 10 to the minus 4 coulombs per kilogram of air. You might see this with older survey meters or certain photon beam calibration procedures.
But it has limitations, right?
Big ones, yeah. It's only defined for photons, X-rays, and gamma rays, typically below about 3 MeV, and only in air. Doesn't work for particles like electrons or protons or in other materials like tissue or water.
And there's no direct SI replacement for exposure as a concept.
Not really. We generally move towards absorbed dose for most practical purposes. There isn't an SI unit for exposure itself.
Which brings us to arguably the most clinically vital quantity in radon-Reshkic, absorbed dose, symbol D.
Absolutely fundamental. Absorbed dose is the mean energy imparted by ionizing radiation to a unit mass of any matter. It tells you how much energy got deposited per unit mass in whatever material you care about. Tumor, healthy tissue, lead, water, anything.
Energy deposition concentration.
Yeah.
And the standard SI unit we use every single day, the one we prescribe in.
That's the gray, abbreviated GIY. 1 gray is defined as absorbing 1 joule of energy per kilogram of matter. So 1 GL equals 1 joule per kilogram, simple as that. When you prescribe 60 gray, you mean 60 joules per kilogram deposited in that tumor.
And the older conventional unit.
That's the RAD, stands for radiation absorbed dose. 1 rad was defined as 100 ergs of energy absorbed per gram of material.
Okay, and this conversion is another one that's just non-negotiable, tested constantly.
Print this on your brain. 1 gray equals 100 rad.
1 gray is 100 rad.
Therefore, 1 centigray, 1/100th of a gray, equals exactly 1 rad. This 1 CDI equals 1 rad conversion is incredibly useful clinically.
Why is it?
Because so many older references, and even some planning systems, used rads. And dose fractions are often around 180 to 200 Cg a rad per day, right? Which translates nicely to 1.8 or 2 gray. So being able to flip between Cg and rad instantly is crucial. 1 Cg equals 1 rad. Don't miss that one.
Excellent point. Okay, so absorbed dose tells us energy deposited, but it doesn't quite tell the whole biological story, does it? Different radiation types, different tissue sensitivities.
Exactly. That's where equivalent dose and effective dose come in, using weighting factors to account for biological effectiveness and tissue sensitivity. But yeah, that's a perfect topic to build on next time, using this foundation.
Perfect segue indeed. So we've covered what radiation does, how we measure it. Now let's talk about the guiding principles for using it safely. The ICRP and NCRP give us 3 fundamental principles. Think of them as the ethical and practical pillars.
Right. Pillar number 1, justification.
Justification, what does that mean?
It means any decision or activity that involves radiation exposure has to produce a net benefit. The good has to outweigh the harm.
So for patients,
For medical exposures, the expected benefit to the patient diagnosis or treatment must be greater than the potential radiation risk. For occupational exposure, the work itself has to be necessary. Simple concept, but fundamental.
okay, principle 2, optimization. And this is where we hear about ALARA, right?
ALARA, the cornerstone. Optimization means that for any justified practice, exposure should be kept as low as reasonably achievable,
Reasonably achievable.
taking economic and social factors into account. It's not about getting to zero exposure. That's often impossible or impractical. It's about minimizing dose where you reasonably can, balancing the effort and cost against how much dose you save. It's a continuous process.
And how do we actually do ALARA in practice? The 3 cardinal rules?
Right, the 3 big levers for minimizing external exposure: time, distance, and shielding.
Time.
Minimize the time you spend in the radiation field. Dose is directly proportional to time. Less time, less dose.
Simple.
Maximize your distance from the source. Dose rate drops off fast with distance. Remember the inverse square law for a point source. Double the distance, you quarter the dose rate. Hugely important, especially with brachytherapy sources or managing scatter radiation.
And shielding.
Use appropriate shielding. Put absorbing material between you and the source. The best material depends on the radiation type. Lead is great for X-rays and gamma rays. Concrete works well for neutrons. And you want low Z materials like plastic, lucite for beta particles to avoid making more X-rays. Bremsstrahlung.
So ALARA isn't just a phrase. It's put into action using time, distance, and shielding. You could almost say as low as reasonably achievable means using time, distance, and shielding to get there.
That's a great way to link it, a good mnemonic.
Oh.
Okay, the third principle, dose limitation.
Dose limitation. This sounds like setting hard caps.
It is, in a sense. This principle says the total dose someone gets from all regulated sources. So, excluding natural background radiation in their own medical exposures shouldn't exceed specific limits set by regulatory bodies like the NCRP or ICRP.
And who do these limits apply to?
Primarily occupationally exposed individuals, radiation workers, and the general public. The goal is twofold. Keep the probability of stochastic effects acceptably low, and completely prevent deterministic effects in these groups.
Now, here's a really critical distinction, often tested, sometimes confused. These dose limits do not apply to patients getting medical radiation right.
Absolutely a crucial point. You would never deny a necessary life-saving radiation treatment just because the dose would exceed, say, the public dose limit.
So for patients, it's back to the first 2 principles.
Exactly. For patients, it's justification: is this treatment necessary and beneficial? And optimization, applying ALARA within the context of achieving the medical goal. You want the dose as low as reasonably achievable to control the tumor while sparing normal tissues. You optimize the medical procedure. You don't cap it based on worker or public limits.
These principles, they're not just abstract ideas. They really guide our daily practice in radiation oncology.
They absolutely do. Every clinical decision involving radiation starts with justification. Does the potential benefit outweigh the risks? Considering both deterministic tissue tolerances and those long-term stochastic risks.
And treatment planning is optimization in action, isn't it?
Prime example, techniques like IMRT, VMAT, SBRT, proton therapy. These are all sophisticated ways to shape the dose, hit the target hard, while minimizing dose to healthy tissues nearby. That's applying ALARA at the planning stage.
And understanding those deterministic thresholds we talked about earlier, spinal cord tolerance, lens dose, kidney limits.
Directly informs the dose constraints we plug into our planning system. They aren't regulatory limits for the patient, but they function as clinical tolerance limits based on preventing severe deterministic harm.
So those advanced techniques are really practical tools for putting optimization into practice.
Definitely. And even things like understanding Röntgen for imaging QA measurements or Gray for diagnostic dose estimates shows the relevance of the units, even if we focus on the principles here. And the biology of deterministic versus stochastic effects underpins everything from tissue tolerance concepts to tumor control probability, which connect to pathology and staging, even if we didn't go into specific organ systems today.
And you could argue that justification and optimization are absolutely core ethical guides for any clinical trial involving radiation, too. Patient safety first.
Couldn't agree more. These concepts are foundational. They might seem simple on the surface, but really getting the nuances and applications is key.
Okay, let's try to boil this down. Some high-yield clinical pearls, perfect for practice and, board review.
Let's do it. Pearl 1. The absolute core difference, deterministic versus stochastic. Deterministic has a threshold. Severity increases with dose. Think tissue reactions like skin changes, cataracts, organ issues. Stochastic. No assumed threshold, LNT model. Probability increases with dose. Severity is independent of dose. Think cancer risk, heritable effects. You have to know this distinction cold.
Pearl 2. That critical absorbed dose conversion, 1 Gray G equals 100 rad. Therefore, 1 centigray CGE equals 1 rad. This pops up all the time in questions, calculations, be able to switch instantly.
Pearl 3. Radioactivity units and the key conversion. Becquerel BQ is SI, 1 disintegration sec. Curie C is conventional, 3.7 by content disec. The magic number, 1C SA, 37 gigabecquerels, GBQ. Know that 37 GBQ conversion.
Pearl 4. The 3 pillars of radiation protection, remember them. Justification, is there a net benefit? Optimization, think ALARA, as low as reasonably achievable using time, distance, shielding, and dose limitation. Those regulatory limits for workers in the public, but crucially not for patient medical doses. Know who the limits apply to.
Those 4 pearls cover the biggest takeaways, the most frequently tested stuff from this fundamental area.
All right, feeling sharp, ready for a quick board blitz to see how well these concepts stuck.
Let's give it a shot. Time to test yourself.
Question 1. An early localized skin reaction such as erythema, which increases in severity with higher radiation doses and only appears above a certain threshold dose, is classified as what type of radiation effect? A. Stochastic effect. B. Genetic effect. C. Deterministic effect. D. Carcinogenic effect.
Okay, keywords here. Increases in severity with higher doses and only appears above a certain threshold dose. That pattern is a dead giveaway for. C. Deterministic effect. Erythema is a classic example of a tissue reaction. They love giving examples like this on boards.
Exactly. Question 2. The principle of ALARA in radiation protection stands for A. All levels are really acceptable. B. Always limit all radiation annually. C. As low as reasonably achievable. D. Avoid low radiation always.
Okay, this one's checking the acronym. We hit this one. ALARA is C. As low as reasonably achievable. It's that core idea behind optimization.
Nailed it. Question 3. A radiation therapy plan delivers 60 grays to a tumor. How many rads is this? A. 6 rad. B. 60 rad. C. 600 rad. D. 6,000 rad.
The conversion. Okay, we know 1 gray equals 100 rad. So 60 grays, you just multiply by 100. 60 times 100 is 6,000. So the answer is D. 6,000 rad. Got to be comfortable with that conversion.
Perfect. Last one. Question 4. Which of the following is not one of the 3 fundamental principles of radiation protection as defined by the ICRP? A. Justification of practice. B. Optimization of protection or ALARA. C. Elimination of all exposure. D. Application of dose limits.
Okay, thinking back to the 3 pillars, justification, optimization, ALARA, and dose limitation were the ones we discussed. What about C, elimination of all exposure? Is that a principle? No, because often elimination isn't possible or even desirable, especially in medicine. ALARA is about minimizing, not eliminating. So the one that's not a principle is C.
Excellent work on the blitz. Now, while these principles are absolutely foundational, the field isn't completely static, right? There's always ongoing discussion.
Absolutely. For instance, we mentioned the linear no threshold model, the LNT, for stochastic effects, assuming any dose carries risk. Well, modeling the actual risks from very low doses of radiation, that's still a big area of scientific study and debate.
Yeah, it's tough to measure those effects directly.
Exactly. Gathering solid epidemiological data at those low levels is incredibly difficult. So while LNT is the basis for our protection standards, research continues to refine our understanding of low-dose effects. It just highlights that even these established principles operate within a framework that science is constantly trying to improve.
It's a good reminder that even the fundamentals have layers of complexity, areas where we're still learning.
Precisely. And mastering these basics gives you the grounding you need to understand those more nuanced discussions and appreciate the boundaries of our current knowledge.
Okay, so let's quickly recap the key points from this whole discussion on foundational radiation protection.
Sounds good. We differentiated the two main types of biological effects. Deterministic, they have a threshold. Severity climbs with dose. Think tissue reactions like skin changes or cataract.
Versus stochastic effects, no threshold assumed under LNT. Probability goes up with dose, but severity is independent, like cancer risk or heritable effects. Got that distinction down.
We reviewed the basic units. Becquerel and Curie for radioactivity, remembering that crucial 1 CI equals 37 GBq conversion. Roentgen for exposure, noting its limitations.
Yep.
And the big one, absorb dose, with gray and rad, hammering home that 1 gray equals 100 rad, meaning 1 CGI
And
equals 1
finally,
rad.
we laid out the 3 cornerstone principles guiding everything. Justification, gotta be a net benefit. Optimization, ALARA, using time, distance, shielding to keep doses low. And dose limitation for workers in the public, but not for patient medical exposures.
These concepts truly are the bedrock. You'll see them reflected in safety protocols, treatment decisions, patient conversations, and definitely on your board exam.
Getting a solid handle on these principles and units isn't just about passing exams, though it definitely helps there. It makes you a safer, more informed, and more confident clinician day in and day out. You're building that essential foundation for all of RadBio, so keep reviewing, keep practicing. You've got this.
Absolutely. And remember, you can find practice questions, work through practice oral boards covering these very topics to really cement your understanding over at radocsmartlearn.com.
And definitely join us for our next session. We'll build directly on today's material, digging deeper into radiation protection limits, and units will tackle equivalent dose, effective dose, those tissue and radiation weighting factors, and the specific dose limits you need to know for occupational and public exposure.
Thanks for tuning in and spending this time with us. Keep up the fantastic work with your studying.